All right. Hi, I'm Dr. Sasha McBain. I'm a clinical psychologist by training and a member of the ISTSS Public Information and Education Production Subcommittee. So we are starting this new series called Conversations with Creators. And so ISTSS really strives to disseminate knowledge and promote high quality education and training to improve access to care and quality of care for those impacted by traumatic stress. And so the ISTSS Public Information and Education Oversight Committee has been tasked with how to develop new and use existing communication channels to disseminate knowledge in order to better meet the needs of ISTSS members, potential members, and our communities. And so to meet this objective, our committee has had the opportunity to collaborate with developers of our interventions that were highlighted in the ISTSS Prevention and Treatment Clinical Guidelines in order to help support widespread dissemination and implementation of the recommended interventions among ISTSS community and the broader public. So I am pleased to welcome Drs. Matt Cordova and Joseph Ruzek, who are the developers of the brief Dyadic intervention, which was highlighted as a multiple session preventative intervention with emerging evidence. So I'm going to pass it over for you to each briefly introduce yourselves.
Sure. I'm Matt Cordova. I'm a psychologist in training. Also, I am an associate professor at Palo Alto University, and I'm also a psychologist at the VA in Northern California, where I'm the mental health training program manager and the psychology training director.
And I'm Joe Ruzek. I'm a enthusiastic long-term member of ISTSS. I'm now affiliated with Palo Alto University in Palo Alto, California, Stanford University, and also the University of Colorado at Colorado Springs. And the work on this dyadic intervention was completed when I was at the National Center for PTSD Dissemination and Training Division in California.
So happy to have both of you. So I'm wondering if we can start, if you can tell us a little bit about what the specific goals and key components of the intervention are. Kind of introduce us to it.
Sure. I think it's useful in drawing attention to the fact that this intervention is a little bit different hypothetical mechanism of influence compared to many early interventions, in the sense that it is focusing on the enablement of emotional processing, but in the interpersonal context, in conversations with close friends, family, loved ones, confidants. So it focuses on increasing perceptions of social support and also decreasing the negative social support and social constraints that have found to worsen acute stress reactions over time. So the goals of the intervention are really several kind of behaviorally. One is to increase disclosure on the part of the survivor about their thoughts and feelings, whatever they would like to talk about their experience, to decrease the social constraints of various kinds that might be put in their path as obstacles by the people that they are disclosing to. That is, sometimes friends and family do things which subtly or not so subtly discourage them from sharing their experience. And then also there's a small component of just trying simply to increase adaptive coping behaviors via some instruction in coping behaviors. But basically we're trying to improve the ability of the supporter to offer real support that's significant and might tap into some important mechanisms of change.
And it's a distinction that this is really focused on the dyad. So we're focused on the interpersonal context of recovery and trying to remove obstacles to natural recovery that happen when people are disclosing about their trauma to the people around them. We know that social support generally is a helpful predictor in terms of long-term adjustment, but what are the specific processes that facilitate adjustment is less well understood. And we think that if we can remove some of those obstacles and facilitate interpersonal processing of the trauma, that's going to help people. And in the long run, these helping relationships are sustained over a great many years. And so we're talking about an intervention that may be brief in its delivery, but that may last for some time in helping that process play out. We also think that we know that these traumatic experiences impact the support people as well. And so helping them manage their own stress in how to respond to their loved one, they can feel more efficacious in providing support to their partner.
Yeah, and Sasha, I would just add to the points that Matt's made. What is in part innovative about this kind of intervention is has the focus to travel with the survivor across time. So ordinarily, you know, a mental health professional or other person meets with a recent trauma survivor, sees them for a limited period of time, even if it's several months of psychotherapy, and then that's the end, right? It's up to the person to have, incorporated these tools into their repertoire and keeping using them. However, here we're interacting with the dyad, and the dyad is a really important dyad, one that's solid, that's a fixture of their life. And so it's likely that they'll continue to interact with their confidant over potentially many years. And so what that means is if we can shape their helping conversations, we produce an intervention which could happen countless times over time. And we think that that might be a game changer for influencing trauma survivors. So partly we hope that this focus on dyads might stimulate more attention to researching larger units of persons rather than just the single trauma survivor, because trauma affects the family members, they experience symptoms and reactions, and it might be a better, more theoretically sound way to look at families or couples as they move forward in time after exposure to trauma.
Mm-hmm. The one thing that I really like about this too is that it takes this idea of social support and it being a protective factor from the theoretical to the practical. Like if that's true, then how do we really maximize the social support in a way that's going to have this long-term impact, and really thinking about, you know, I think sometimes our trauma therapies really think only about the individual and not the individual within context. And this intervention is an opportunity to really expand that at least one degree, and how we're treating and healing trauma in the room and outside of the room.
Well, and I like your point because, heretofore, there's been a lot of research. One of the most robust findings in trauma psychology is the relationship of perceived social support to well-being after trauma. But actually, very, very few psychological interventions specifically target social support processes. So it's a little bit different. We'd like to see more of that done too.
Yeah. Thank you. Tell me a little bit more about if there's a specific population for the intervention or some of the work done around who's actually best to receive this.
Well, the intervention was conceived as being directed at recent survivors of trauma, in the first weeks and months post-trauma. And our study, the study that the RCT that was done in collaboration with Alain, Brunet, and others, focused on motor vehicle accident survivors and survivors of non-interpersonal trauma. So in some sense, perhaps a less complex form of trauma, at least for some people. We are now collaborating with Dr. Emily Dworkin at the University of Washington to adapt the dyadic intervention for sexual assault survivors. So we're about to try to extend it. I think, according to what we think the mechanisms of change are in this thing, they're ubiquitous across trauma populations. So I think we believe that it could very likely be extended for disaster mental health and for people exposed to all kinds of adverse events, because the helping mechanisms are so fundamental. But that needs evaluation, as does the entire intervention.
Also, when we first designed this, we were also thinking in terms of people's response to acute illness, like dealing with cancer or another life-threatening condition. And a lot of the early work around social constraints was done around life-threatening illness and looking at oncology populations. And these social dynamics that arise where loved ones unintentionally suppress disclosure are so common in trauma survivors in general, and in illness populations and folks who have dealt with other traumatic experiences, that we really think this is portable across different populations.
Tell me a little bit about how you measure treatment outcomes to determine if this intervention is really having its desired impact on participants, and do you measure for the patient and the support person?
We think that using standardized measures of the kind of usual suspect outcomes, so PTSD symptoms, depression, certainly are important. We also think that it's important to be looking at other outcomes that tend to get neglected. So functional outcomes, alcohol and drug use, relationship functioning, work functioning, and role functioning. Another thing that we're interested in is looking at some of the things that would be indicators of mechanisms. So there's an amazingly little research on how much people talk and how people talk post-trauma to their loved ones. And so we're interested in looking at frequency of desired talking, how much people actually talk, what they talk about, emotions, facts. So getting at some of the mechanisms of disclosure, perceptions of support. How much do I perceive that my loved one is constraining or responding negatively to disclosure? And also, as you mentioned, understanding what the support person is experiencing as well seems like an important thing to be measuring.
Tell me a little bit about how you ensure that the intervention is culturally sensitive for diverse populations, given that this intervention can be so portable.
Well, we think that's a very important question, and one that we hope researchers will take up and look at in more detail. Because it seems especially likely that in this kind of interpersonal intervention, it focuses on sharing of distress and sharing of personal information, that cultural factors might be even more important, and they might show up in some other kinds of intervention, because it's widely accepted that different cultural groups may have different norms regarding disclosure. There might be in some communities more shame that it was within the family constraints on disclosure, and different rules and styles of responding to trauma and also sharing personal information. So we are actually, in the work that I described on adaptation for sexual assault survivors, we are working with a team of experts in cultural adaptation to look at how best to adapt this for individuals. Obviously we need to adapt it to the culture of sexual assault, but we also think that it needs to be looked at different ethnicities. We have some interest internationally in this kind of an intervention where in collectivist cultures, there may be different rules for disclosure. So it's an important question. What we did try to do to build into the intervention is we built in ongoing efforts to check for response to the ideas, so that we hope that will enable some increased sensitivity to how it's playing with the recipients and whether it needs to be adapted in different ways.
Also built in are some questions, kind of motivational interviewing-esque, with, what are the pros and cons of talking, of initiating conversations, of responding when you feel like your partner isn't hearing you or responding in a helpful way. What are the kind of ways that you would feel comfortable responding to that and giving them some language to do that? So we really are kind of trying to put it in the hands of the participant to figure out how they can use some of this material, but without being didactic and directive about it.
Yeah, one thing that I was thinking about as you were talking is Juliet McClendon recently I saw a blip on her Twitter that she did a talk and was kind of reflecting on the experience of Black Americans and family units. And I think that, not having to think about it just in some of the traditional ways that we think about what family or support is. And so I think this intervention is really flexible too. And people get to choose who their support person is. It doesn't need to be a spouse. It doesn't need to be, whatever traditional means we think of when we think of social support. It can really be whoever that trusted other is for that person, which I think gives it a lot more opportunity to adapt and really be responsive to people's support systems based on their cultural backgrounds, which I think is great. So that
And that,
flexibility.
by the way, that I think is a very important point, because were it targeted automatically at someone in the family, a spouse or a person in a relationship, this might not be the best person to target, because there are people who unfortunately are locked into relationships that don't work too well, and many families that can't talk about such issues. So also, we're aware that some people are relatively isolated and or live alone or not in relationships with families, and so this gives them enormous flexibility, and they are the gatekeepers as to who they have some confidence about inviting into their personal experience. And part of the intervention is helping them determine who it is they want to invite.
What resources and training are required to implement this intervention? So if somebody's kind of thinking about wanting to actually get this up and running, what do they need to be thinking about?
We've really thought of this as a low burden intervention that could be disseminated widely and delivered by people that don't necessarily have specialized mental health training background, which again is kind of the point in an early intervention, being able to roll it out in a number of settings to people that don't require a lot of extra training. So we think that this could be delivered by existing staff in medical or mental health settings. So this could be nurses, social workers, either medical staff, folks that may not have psychotherapy training per se. It's a 2-session intervention, so it doesn't require a lot of time. We've done trainings that have constituted basically a half day of teaching components and doing some role play and talking about special considerations and challenges that might come up. So it could be taught in a pretty concise way, and then with follow-up supervision and monitoring, we think that would be enough to teach people and get them up and running, which is in fact what was done in the randomized trial. We also think that there may be some opportunity to use some supportive technologies. So this could be kind of web-based or app-based things that could help prompt people once they've been exposed to the intervention, and also help the staff have resources that they could follow even after the training has concluded.
It's worth noting that the RCT that was conducted in Montreal was delivered by nurses, not by mental health professionals. So the trial evidence, the evidence we have, suggests that it can be delivered by sort of healthcare professionals who do not have a psychological specific training or training in trauma.
Yeah, I think too, from like a D&I perspective, thinking about implementation, it's a pragmatic intervention, right? Because if we're thinking about early trauma and avoidance being a core component of the disorder that we're trying to prevent, being able to leverage integrated care and getting to the people where they're at, yep, feels like a really good way to go about prevention and early intervention, and also can get around some of the the other barriers that come up when people are attempting to access trauma treatment. And so being able to do that task shifting is a really important piece, I think.
When we first talked about this intervention and designed it, we likened it to the kinds of education that you get about a wound. If you're traumatically injured and you show up in the hospital, they send you home with paperwork saying, well, keep an eye on it. This might happen, that might happen. And if this happens, you could do this to treat it. The same kind of thing with an early intervention for trauma, helping forecast some of the social dynamics that come up after a traumatic event, helping people prepare for those and anticipate ways to not constrain one another, and then also to respond when feeling constrained. So yeah, this really is well integrated into ongoing care.
I'll also say that in our beginning work with sexual assault survivors, we are told that the sexual assault provider community is responding with wild enthusiasm to this. All the different agencies are lining up, wanting to be trained. The sexual assault nurse examiners, people are enthusiastic in the rape crisis centers. So I hope that's the case. It fits in with people's ideas about something that may be valuable. And the brevity is, the 2-session nature of it is quite amazing. I mean, I think I'll say that I was surprised at the efficacy of this thing, given its brevity. I think it's probably the most brief, evidence-based early intervention so far.
Yeah. You've mentioned that you've done more formal trainings. For those who are listening to this and are interested in being trained in this intervention or learning more, are there opportunities for training for folks?
Well, we have not set those up, but I'll say that I'll speak for myself, and I think Matt would agree with me that if there are groups, research teams, or if there are agencies, hospitals, groups that work with different survivor populations, we would be delighted to explore that with them and offer training. Because I'll speak for myself, I would really like to see this experimented with more widely. I will say that the evidence base for this is very limited at present. So our findings need to be replicated, needs to be studied. So we would like to encourage more take-up of this and clinical and research learning.
Tell me a little bit more about thinking about sustainability of the intervention. Like, how do you really get it embedded in a system? Like, what needs to happen?
Well, I think if a organization, let's say, we trialed it in a hospital, the hospital wants to take this up and use it, the key thing would be to embed the ongoing training capacity within the organization, because there's turnover in staff, so they need to have that internal. That would not be difficult. This is one of the advantages of the intervention is it's conceptually relatively simple. It's manualized. We are developing formal training materials for it. So, but it would need to be embedded in a place by identifying and training trainers. It also needs to be integrated into the administrative and clinical workflows. People in a lot of settings are doing already a set of tasks. We think that because the intervention is relatively brief, it could be integrated in the workflows of nurses and others, but that needs to be thought through in some detail and discussed within the organization, because it adds to patient contact time. And therefore, part of what it takes for sustainability is that there needs to be ongoing leadership support. The leadership need to buy into this, support its delivery and incorporation into the programming. But we need to have more implementation science research on this too, in the sense of look at what are the factors that enable the intervention to persist across time after the initial startup projects go. Because as you know, being an implementation scientist, it's the most common outcome is after the founders of an intervention depart, the thing fizzles out over time.
Agencies that we're talking with really feel like this can make a difference and can be implemented. I think that the challenge is having adequate upfront training and then staffing to maintain it over time. We think that it's going to be important to keep evaluating how it plays out with the participants and the patient population you're working with and what needs to be adapted. This goes to the kind of cultural adaptation, but also adaptation to the specific setting and population you're dealing with. So for instance, with the sexual assault studies that are happening at UW, we're finding that specific attention to how the survivor's partner might respond or loved one might respond requires some adaptation. So needing to be thinking about who the family members are that might be involved, and also what kinds of trauma that they're responding to and what are some of the patterns specific to that kind of trauma. So we're going to need to evaluate across settings how this plays out. And as Joe said, we really need to be studying this in an ongoing way, because we have a pretty limited evidence base at this point.
So we can't get away with not talking about COVID and how thinking about unique challenges that have come up or could come up for those who are motivated to be implementing during this time, or if other things, who knows what can come up. So thinking about, in this current context or kind of our current environment, how has COVID impacted how you're thinking about the intervention or its implementation?
You know, the pandemic has limited people clearly in a multitude of ways, but one of them is having the kinds of face-to-face contact that promotes intimate disclosure. And in such a prolonged period where people have been cut off from supports, and despite all the beauty of telehealth, sometimes, you know, talking specifically about trauma or about stigmatized or emotion-laden topics might be harder in a setting where you're not sure who else is in the room or where you worry about confidentiality. That has probably limited people's ability to process interpersonally things that they've been through. And so I think it's made this kind of an intervention that focuses on dyadic processes even more important, but it also is a challenge to figure out how to deliver this in a way that truly will make change in how people talk. We also know people are just more stressed in general, so that both the support people and the trauma survivor have been under more pressure and under more strain. And so that's going to make supporting one another in general more challenging.
And I would add 2 points to what Matt has described. One is that there are some high risk groups in the COVID pandemic, the first responder community and the healthcare workers. And, you know, as we know, it's been difficult to get healthcare workers to go to formal mental health counseling, amongst other things. They don't have much time over and above, you know, the busy workload and toll of their experience. So, you know, it's in those communities where peer systems, you know, have got some traction, particularly in first responder groups. So we think that this could be adapted for dyads of healthcare workers or of first responders, you know, and open it up. It would not be a designated trauma survivor. It would be a two-way thing for each person to communicate and not constrain the disclosures of the other person. And I think that integrating this kind of dyadic mutual support into, say, hospital programs would be a significant advance. And it would also help to ground some of the peer interventions in something that's more theoretically sound and maybe pack in some more muscular forms of change into it. And the other thing is that, you know, we have modified the intervention for telehealth delivery, obviously in COVID, but more generally. And it also, that opens up some useful things. For example, we've built a slide presentation that can be viewed during the Zoom session that will help that helps in the education regarding the didactic elements of the intervention. So there are, you know, advantages in some sense to doing this via telehealth. But I do think that the integration of this kind of intervention into peer programs generally and to workforce programs would be a step forward. And we'd love to collaborate with people on that if there's interest.
I'd add one other thing, which is, you know, we think of social constraints, which this intervention is targeting, as an interpersonal process. Clearly, there are constraining cultural workplaces and professions. And so some of the ideas that about where mental health issues are stigmatized or where disclosure of emotion is frowned upon, those overt or covert messages that get disseminated in our society and in certain work settings and in certain professions, kind of the idea of toughness and not letting things bother you or keeping clinical distance, can sometimes inhibit people disclosing. And especially if people are worried that their job performance will be somehow negatively viewed or they'll be negatively viewed socially, that may have an internalized stigma impact on the traumatized person. And so we think that this process is important in dyads, but maybe we need to be thinking also about kind of systemic things that can be socially constraining and inhibit processing of trauma in general.
Yeah, it's a great point. And thinking about, like, how do you have the organization as the person receiving, you know, the entity receiving the intervention, and thinking about this at those multiple levels, the individual relationships, but like you said, within the context that somebody's living and working in, I think is a really good point. This has been really a fun conversation. I know that people are going to be much more interested in this moving forward and getting the word out about this intervention. Is there any last words that you have for those watching about the intervention?
Well, only my piece would be, I think it's kind of a game changer to move beyond the individual's trauma experience, because trauma is a social experience as well. So, and yet at ISTSS, as a research community, I don't think that we have looked all that much at the all of the different kinds of interactions and how those change, especially in the acute and then first weeks and months after trauma. I think there's a big opportunity to develop an entirely different class of interventions. You know, Matt and I, we focused on social constraints and disclosure, but there are a lot of other things that happen in interpersonal support experiences, things that could be targeted, trained, and strengthened in different ways. So this idea of focusing on small groups, I mean, it could also focus on groups of friends, right? Those kinds of interventions don't exist. So, you know, I think, Matt, one of my sources of excitement about this is to try to break open some of the thinking about the design of interventions. And I think the things we do now are very good and promising, but I think there is a wider array of potential interventions, mechanisms, as well as, you know, locuses of delivery that could be explored. And I hope that this will help people do that. And thank you for the opportunity to present this a little bit to the ISTSS membership.
Yeah, it's been great to talk with you and to think about this. I think that in a way, this is a strengths-based approach that's trying to remove obstacles so that people's natural kind of support processes can play out. And so thinking in terms of prevention, maybe that's one of the things we can also be thinking about is what are the things that inhibit and get in the way, and how can we get in early and on a wide scale to prevent some of those obstacles from getting entrenched.
Thank you both so much. And we'll be linking the papers that kind of go through all the components of the intervention on the website. It sounds like you're both open to being reached out to individually for more information. So thank you so much for your time.
Thank you.
We'll end there.
Thank you, Sasha. Thank you, Matt.